into week 3. So hopefully everyone is doing well. And in the event, just as my disclaimer, in the event that you have connectivity issues, you lose connectivity, or if I lose connectivity, because I know this is like a little storm system that's going through, just hold still, log back in. If I lose connectivity, just hold still. I'll try to log in on a different device. Just as a reminder, these sessions are recorded and they are viewed by the attendance administrators. I need you to look at your name. Ensure that your first name and your last name is how it appears on Fortis's rosters. This is very important in the event that once the attendance administrators go back and look at this recording, that it correctly shows that you were here. A lot of times when we log in, as I mentioned earlier, in weeks past, that it logs us in with the last name that it remembered your device will. And sometimes it leaves off your last name. Ensure that you have your first name and your last name listed there. And in order to change that, let's see, you click on the 3 dots. Your view may be different from mine. There are 3 little dots that are there, and I'm sure there's a word for them. And you go down to rename and just make sure that your name matches. In the event that you are going through a name change, make sure, and it has not occurred yet, make sure that your name matches how it is listed on Fortis's roster. All right. In the event that you have to step away from the camera, place a message in the chat to myself. Do not send it out to everyone. And so you're expected to be on camera unless we are on break or something like that. All right. So we've talked about all about housekeeping details that we talk about weekly. So the next thing that we need to talk about is, we do have our exam on next week. For the most part, you all, I think all classes, that first exam, if you're taking more than one class, you have several exams next week, week 4. So you must complete. Let me go to this announcement and make sure I read it. We haven't placed it in the announcements yet. Let me go ahead and read it so you'll know what will be there and what is expected here. It's coming from Dean Brown. In the past, the practice exam was there for each course. And so it's pretty, if you're using the same device, some of you all just completed that one practice exam and you made it through, you changed whatever specifications ExamSoft wanted you to do, you did that. But now for each course that you are enrolled, you are being asked to complete the practice exam in ExamSoft. For each class that you're in, it is mandatory that you complete this. If you do not complete the practice exam and you're having if you have issues being able to download your exam or get into Exemplify to work on your computer, you will be classified as not being prepared for the class. It will be subjected to the late exam policy with a 10% deduction. And so what that means is you're going to complete that prior to actually downloading your exams. And this is a request for all of your courses. And the thing is, and make sure that you're using the device that you're going to use on exam day, because what Exemplify does, it goes through the specifications on your computer just to make sure that they match. So those practice exams, they are not voluntary. You must complete them. If you're in 3 classes, you need to go through each one of those courses in ExamSoft and complete the practice exam for each one. It is mandatory. And so that announcement will be placed in the announcement section in your courses before today is over. So I just want to give you heads up on that. And so it does take away the anxiety, taking away the you not being focused, but sometimes you'll get in there and ExamSoft, your specifications on your computer, they don't match. And so then you're having to scramble to figure out what it is. You're having to make that phone call, and that takes away your focus from taking an exam and doing your best. So just make sure that the announcement was already placed out in the announcement section with the code there. The password is Fortis02 or either Fortis01, I think, for all of the courses. So just make sure that you have done that before exam day. And then, like I said, I'll post that additional announcement from Dean Brown in the announcement section here. So you can refer back to it. All right. So we will take our quiz at the latter part. So let's go on and look at some of our content, because as we know, exam 1 is on next week. So let's go ahead and start looking at our content. Let me share my screen here. Okay, let's look at this one first. So I want to send this out. Let's do a little group activity here. We're just going to look at a few concepts, and then we'll pull back together here. Okay, let me share my screen. So we're going to do a whole group, then we're going to go to groups, and then we're going to come back to whole group. So again, place your name and campus in the chat if you have not done so. Trying to show you all. Here we go, right here. Right, concurrence. There we go. Okay, so this nursing process, it is really our friend. It helps us to critically think. It helps us to be organized. It keeps us so that we don't miss any significant information as we're interacting with our patients. Yes. So the question is, do we have, as someone texts me, we do have a quiz tonight. The exam is next week. So we're clear on that, but we're going to take the quiz later on. So this nursing process, we do need to understand and remember who does what. While the LPN is not an independent practitioner, we do function more independently in parts of this nursing process. So the assessment part, the RN and the LPN, they gather that information independently, subjective, objective data. So someone tell me give me an example of subjective data. What is an example of subjective data? Come on.
The patient tells you.
What the person, the client, the patient, the resident, what they tell you, okay? How else can we reword that? Or can we reword it in a different way? Subjective data. How do you know what is subjective data? We had a list on the screen. What would help you? What definition would you go back to determine? Yes, that data is subjective. Nope, that data is objective. What is objective data?
The facts, like vitals and whatever you collect.
All your senses and not taste.
Okay. That information that you collect by using 4 of your 5 senses. Got it. So that blood pressure reading measurement that you get, you're using your sense of sight and the hearing. Good. You're touching that skin. You're palpating that skin. It's cool. It's warm. So that information that you're gathering. Good. So the assessment, the RN and LPN, they gather that data. They do it independently. And so doing the assessment and then the implementation, the doing part, the action part, those are the two parts of the nursing process for the LPN where we function more independently. We're not independent practitioners, but we function more independently there. So the diagnosis part, the RN uses NANDA. And we know that NANDA, I like to say, is proper. We say tomato and NANDA says tomato. So an example would be a person that has an increased blood pressure or heart rate that's high or low. NANDA listed as potential for decrease or increased cardiac output. So we're essentially saying the same thing. But the RN uses NANDA to come up with that diagnosis. Doing the planning is when the RN and LPN, they collaborate together. Implementation is the RN can independently carry out those orders, whatever those interventions are. And let me mention here to you all, we can reinforce teaching. Reinforced teaching could be an implementation. We are reinforcing that teaching. Sometimes we think because we're teaching, it is not a doing part, and it actually is implementation. We don't do the initial teaching, but we can reinforce. An example of implementation could be also reinforcing teaching. It could be administering that medication. It can be administering that tube feeding. That's the doing part, the action part. And then the evaluation part, the RN and the LPN, they look at they report the information, and then there's a decision made. Was this goal met? Was the goal not met? And then also doing this evaluation piece, what we're adding in is to reassess our evaluation. What do we mean by that? For example, we're checking vital signs every 4 hours. Looking back at the implementation at 8 o'clock, 8 a.m., we check vital signs. Blood pressure, everything was within normal limits. We checked the vital signs again at noon, everything was in normal limits. During this evaluation period, we can say the goal was met because we checked those vital signs. But then we want to look and see, well, hey, do we still need to check these vital signs every 4 hours? Do we need to check them more often or less often? So that's just that piece they're adding in. But nevertheless, the assessment and the implementation phase is where the LPN functions more in an independent role. And that leads us to our next slide. The LPN functions in an independent role in the nursing process by collecting data from a client and also implementing doing those interventions. The RN creates the nursing diagnosis. The LPN collaborates with the RN on the plan of care. We always want to think about safety. Safety, consider the environment. Is it, because if we're in the hospital setting, even if the person's in a nursing home, they're not in their home-like environment. So things are not so or positioned like they're at home. And that lighting, those things that we really don't think are really important, it could be a safety issue for our patients. So they're at risk for falling. So we always want to consider safety, making sure beds are in the lowest position. Ensure that those rugs have that non-slid padding up under them. Make sure things are well lit, making sure call lights are in reach. I always want to consider the safetyness. And then before collaborating on the plan of care with the RN, the LPN must assess the client's understanding first. We always want to see, well, what do the client understand about what is going on with them? Because then that helps you interact with them and also be able to reinforce that teaching and come up with interventions to do. Because if interventions, for example, are to check your glucose, do finger sticks every, before meals, then that person does not understand, what's the importance of even checking, doing a finger stick, what diabetes is, what that number that they get, what does that mean? Then the patient might be non-compliant. So we do want to understand and assess the client's understanding first of the disease process, of whatever it is, those interventions that we have for them to do in that teaching that we're reinforcing. Okay. So we kind of already went into this slide here. The RN does that initial patient teaching and plan of care. Then we come in, the LPNs, we reinforce that teaching. And then reinforcement also includes that falls under that implementation part of the nursing process. And then, of course, we collaborate with the RN. So if you have any questions, please come off mute or either place them in the chat and I'll check the chat periodically just to make sure that I'm answering everything. So reinforcing teaching falls under that implementation phase. Sometimes we kind of think that we kind of forget that teaching part, that conversation, that is very important. Is that intervention is an action item. So the U.S. Department of Vocational Education, they've come up with these 4 terms to describe our scope. So they've looked at everything that we do, and we really do wear many, many hats. Depends on what setting you're in, depends on the life stage, from birth all the way to providing that postmortem care. but they've looked at and they've decided these 4 words describe our scope of practice. And so make sure that you know these terms: judge, recognize, determine, and appraise. It's like, well, how did they narrow down all that we do to these 4 terms? But they did. So our scope of practice, remember, is our to-do list, is those things that we can lawfully do. And so these terms are used: judge, recognize, determine, and we appraise. Okay, subjective and objective data. And we do know that some data can be obtained from the chart, and that is still objective data as well as just chart obtained. So subjective, someone mentioned earlier, the patient, the client, is those things that they are telling us. My pain is a 7. I feel nauseous. I am hungry. Even their mood, I feel sad today. And then objective are those vital signs, the information that we are gathering using 4 of our 5 senses. Okay. That wound appearance, we're documenting the 3 measurements, whether or not it has drainage. We're telling about the area, the skin around that wound. And then that patient level of consciousness, when we are asking them, can you tell me who you are, why you're here, that orientation level. Are they alert and confused? These things that we have observed. Okay. Again, safety is priority for patient care and the best outcomes. So what are some areas that the nurse can provide safe care in with a client that's lightheaded? So I'm going to pause here. I'm going to give you all, let's see, let's do 5 minutes. So in the chat, put number 1 and then put number 2 and number 3. So for each of these, list some areas that we can provide safe care, some things that we need to be thinking about. And safety is our concern. So just list 1, 2, and 3. And for each, just list an intervention or something that we need to consider or do if a patient is lightheaded. If a patient is 3 hours post-op, not 3 days, not 3 weeks, but 3 hours post-op. If our patient is having respiratory difficulties. So let me put a timer on. So, and just send it out to everyone. So what are some things that we need to be thinking about to keep this patient safe? And I will set the timer, give you 5 minutes, send it out to everyone in the chat. So the task is in the chat. You're responding to all 3, but just place 1, 2, and 3. And we're trying to consider some interventions, some things that we need to think about or we might do if a client is lightheaded, if a client is 3 hours post-op. Okay, got my timer going. And then if they're having respiratory difficulties. Okay, 3 minutes, 38 seconds left. So the task at hand is to type in the chat a response. What are some areas that we need to do or consider? What are some things that we can do? What are some interventions? What should we do if a client is lightheaded? If a client is 3 hours post-op, what are some things that we might do or consider? What should we do if a person has respiratory difficulties? And send it out, the responses out to everyone. 3 minutes left. We have 1 minute, 41 seconds left. So after you post, be sure to look at what others have posted. And we'll go over here in just a few minutes. Looking good though. Looking good. Okay, looks like we have responses from everyone. And so, I don't want to say that it's simple, but having that patient just reminded them change position slowly, raising the head of that bed, getting that person up and getting that head up so that that chest can fully expand. Those things are really, really important. Go back to my PowerPoint here. Having that call light in reach, and then making sure that bed is in that lowest position. So in the event that they do, stumble or at risk for falling, then that height is lower. And so if there's an injury, hopefully it won't be as bad in the event that that bed was, up at our weight, at least at waist level, because we work from waist level. So imagining someone falling from that height. And so lightheadedness, just reminding them that, use that call light, checking those vital signs, fall precautions. We do in the hospital settings, you replace those bands on. And I've even seen in some long-term care facilities, a person that's had frequent falls, they have like apples or a tree or something with the apple, because it just reminds you that this person is a fall risk. And so that you can provide those reminders. Hey, you should call light in the event that you're lightheaded. And then if this is a new finding, we're doing those vital signs and then making sure that we're reporting this new finding. And then also you have some people that have chronic, what they call it vertigo, and they have that lightheadedness, and then they're dizzy and they're unsteady. And so they might be on medication. If they continue to have it, that medication might need to be changed. So we do need to just remember that we're also reporting those findings. Those non-skid socks. Okay. 3 hours post-op. So those compression devices, we might have to administer those anticoagulants. 3 hours post-op. Remember, all those nerves are coming back to life. So we want to monitor that pain, to make sure that we're doing those pain assessments and reporting those findings. And of course, vital signs. Good. And then head of bed, raising that head of bed, changing that person's position. I don't think anyone put incentive spirometer, but yes, deep breathing exercise and using that oxygen. But get just a lot of times just changing that person's position, getting that because they get in that little hole, I call it a little hole, that little groove in that rib cage, it can't expand. And then they're not feeling good. And so getting them up, changing that position. All right, good. Thank you all for participating. All right, so here it is. The LPN will most often reinforce the client's teaching. We have said that. And then notice changes needed to the care plan during the implementation phase of the nursing process. The implementation phase, you need to know that. Nursing interventions are patient specific. Remember, we provide that individualized care. Those care plans, when the businesses buy those packages, they're standard. So everything about a disease process, everything about a broken arm, everything about diabetes will populate. But we go in and remove those options that are not specific to our clients. We take those options out because remember, we provide individualized, specific, specified care for each of our clients. And the example that I always give is we have 5 patients that have hypertension. We have 5 patients that have diabetes, but still their care plans would be different. They would be individualized. Okay. But during the implementation phase is where we would notice those changes that are need to be made. And so once we collaborate with the RN, we can let them know. But it's usually during this phase right here when we're reinforcing that teaching, and we realize that this client still does not understand what we're trying to get them to do. And also during the implementation phase, we're doing that dressing change. This wound has not improved. So that is where we notice those changes that need, and we collaborate with the RN thereafter. Okay. When collaborating with the RN, plans of care outcomes should be measurable, realistic, and time specific. We need to know when, where, how, all of that, and time specific. Rather than just saying check vital signs, we need to know check vital signs every 4 hours. Which hours? At 8 a.m. and noon, or whatever those times are. Making sure that things are realistic. Okay, let's do a knowledge check here. Which care plan, and in the chat, you can place, hold on, let me make sure I don't put the answer there. Okay, I think these are the answer choices. So in the chat, you can just respond by saying 1, 2, 3, or 4. I'm gonna let you read through it, and then in the chat, 1, 2, 3, or 4. Okay, let me see what our responses are. For the most part, we are saying 1. Let's see. Let's see. We in this PowerPoint. All right, and we have it. We provide that individualized, that specific care. Got it. Good. All right, client-centered, relationship-centered. Try to move us over here. Okay, providing care that is respectful of and responsive to the individual client preferences, their needs, their values, and ensuring that the client values guide all clinical decisions. We want to make sure that we know whether or not this patient understands their disease process. What do they know about it? We need to know. We need to get them in on it because we may think, that the intervention needs to be, and it could be that intervention, but we need to also incorporate some client teaching and whatever their preferences are. As long as it's not going to cause them any harm and us any harm, we want to include those practices and those client preferences into the interventions. All right, let's talk about communication. Closed and open. So how do you tell the difference? And 2 people, 3 people come off of you and tell us, how do you remember what is a closed question and an open question? How do you determine which is which? Let me hear from you.
Close is kind of just a yes or no, and open, they give you more details about like your question, what you're asking them.
Okay, thank you for sharing. Anyone else? How do you remember? And if you're restating pretty much the same, still let's hear it, because the more we hear this, it'll stick with us, and our little bells and whistles will go off, and we'll have a better understanding. Our foundation will be great. So two more people. How do you understand and remember, or what's your definition if you're explaining to the group? What would you say about
I would say,
close?
oh,
Go
sorry.
ahead. Go ahead.
I was going to say open communication would give you more of like a conversation between like the patient and the nurse, whereas like closed communication is just it's straight to the point, like asking them questions.
Mm-hmm. Go on. Mm-hmm. Go on. Is that closed or open? That statement that I'm making in reference to.
Closed.
Mm-hmm. Go on.
Oh, it's open.
That's open because I'm getting more information. I was giving an example of what you just said. Tell us your definition again. What is the open communication?
Me?
Yes.
Oh, just being able to like have a conversation and get more details with it.
So doing that conversation. Mm-hmm. Go on. And so that's like active listening. You wanting that person to just keep on talking and give as much detail as they can. Because initially, once we start talking, or the patient starts talking, they're trying to get it together. But if you encourage them to go on, it does exactly what she just said. Open communications give more details. And then therefore we have more facts. We can gain a better understanding of what it is that the patient is trying to communicate with us. So open gives us that. And so that was an example, that statement that I was making, go on. That is an example of active listening, because and open communication. And as you all mentioned, close, you pretty much just gonna get a yes or a no. Are you hungry? Yes. Are you hungry? No. But with open, there is a more conversation. There's opportunity to gain more information. And there's sometimes if the client don't want to be bothered, they will take your open statement and flip it into a closed statement. And so, but you want to still try to establish that therapeutic relationship with them so that they will open up, so that you can provide that specific care like we just talked about in this slide right here. So we can include their preferences in it. And that's all part of providing that care to them. All right. So let's talk about this S bar here. We need to know the 4 parts and then what falls under each part. So the situation, what is the reason that we are calling? Are we calling to report lab results? Are we calling because there's been a change in mental status? Why are we calling? So when we call, we want to include who we are, which unit you're on, the patient's name, and then what is going on. What is that reason that we're actually calling? And then we need to provide some background, just so that we can that healthcare provider can remember which patient we really are talking about. Because remember, this is usually over the phone, and so that helps them also to make a decision about what's the next steps for us. If we do want to give that background, why are they here? What was their admitting diagnosis? Is this the reason that we're calling? Is this something new? Or is this directly linked to the reason that the patient is here initially? How long had they been here? What was that date of admission? What is the status, their current status? So I always want vital signs, medications that we just administer. We want to give those allergies, because if they're given an order for a new medication, that we need to let them know about those allergies as part of their background, so they don't order a medicine that they're allergic to. Now, pharmacy usually will catch it, but if we already report the allergies, they will know, because they usually have like their list of first meds that they'll order. And so reporting those allergies up front will eliminate that recall and that chance of us committing a medication error, because sometimes those though they're not caught. And so, but who's at fault if we give that medicine? It's us because we really administer. So you want to make sure that you give that background information, the allergies, their IV fluids, and their code status. All that is really important. Because if we have a patient that's do not resuscitate, do not intubate, do not travel, transport, all these different code statuses, and then and those things are legal. They have that information as a legal document, and then we do the opposite, then we have caused harm. So the assessment, what do you think is going on based on the data findings? And so we give those assessment findings. You know, we go in, we did the wound change, and we give a descriptive of what the description of what the wound looked like. You know, what were our assessment findings? And then that recommendation, goals of care, what needs to be done, including the consult, medication order. This patient might need to be transferred to the hospital. This person might need to be transferred to ICU. So they're closely related. This person may need to go down, you know, to have an urgent, you know, procedure or something. Now, what are those recommendations? So make sure that we know what is under each part and then being able to apply it to a example. So S-bar can be used for handoff as well. We're changing shifts. So S-bar helps us to keep everything organized so we don't forget anything about our patients. There are small differences when we are actually handing off or making a call to that physician and when we're just changing shifts. So the situations that change in shift, that mission date, their chief complaint, and their diagnosis, you know, their background. I'm not sure if you all have been set in on the change in shifts when you're at clinicals and kind of hear this and this discussion. Some facilities do it at bedside. They also have the printed cardexes. I don't want to date myself, but we even used to actually record and so that they can go back and refer to. And that was just another layer that was there. So you had the paper, you had the one-on-one, and then you had it recorded on this device. And you played it back and you just recorded over it. So you had it several different ways. But that background, that medical history, of course, the allergies, the code, you're going to need to know your code status of all your patients every time. Any lab results, the location of the IV. You know, is it time to be changed? Is this day 2 for this IV? So that we can go ahead and start planning, well, you know, on day 3, it needs to be changed. So we have another 24 hours. This right now is in the left arm, left hand, or wherever it's located. Their mobility, their pain management strategy, and then the responses to those interventions. So the patient is being non-compliant with whatever, then we need to still know what their response is or receptive to those interventions. We need to know those responses. So pass that along. And then the assessment part. What are their vital signs? What was their pain assessment? Did they have any tests done? What were those results? Are they at fall risk? What medications did you prescribe? Especially if you're prescribing PRNs that needs to be followed up on. So make sure that we are providing that information. And again, recommendation, goals of care, what needs to be done. Well, we checked vital signs at noon and they were stable. But right now we still have that order for the next 4 hours. So they're due again at 4 p.m. So you just, you know, reminded them of that. Okay. We kind of start talking about active listening early on. But active listening, the most important part of communication, particularly therapeutic communication. So we want to make sure that whatever the information the sender is sending, that the receiver actually receives it correctly. There are times when we're having a conversation and what the sender sent was misinterpreted by the receiver. So we want to make sure that we use our active listening skills to ensure that we are getting the correct information and so that we can, you know, be able to provide that best care for our patient. Key factors in active listening: purpose, discipline, attention, and focus. We want to be giving them our undivided attention. Clarify what you think you understood the client is saying, and then ask more questions. Ask more open-ended questions to gather more information if needed. You know, and here it is. I was just gonna say, restate things, repeating what the patient said in a slightly different way. These active listening techniques, they're good so that things are not misinterpreted. Gives that client a chance to correct us. Okay. Clarifying. You need to know each of these. So I make sure I read through these. Restating. Repeating what the patient said in a slightly different way. Clarifying, you're asking questions in a response to what the patient has said, to be sure. All of these are to be sure that we are understanding what information the sender has sent us. Okay, and then reflecting, putting into words the information that we receive from the patient at an effective communication level. So making sure that we're speaking in lay terms. Paraphrasing, expressing your own words and what you think the patient means. So we're also familiar with this paraphrasing. Minimum encouraging. And that's what I was doing. I think when Leanna was, I think it was Leanna that was giving us that definition about open-ended, using sounds or words to encourage the patient to continue. That was an example. Minimum encouraging. So that head motion or yes, okay, tell me more, go on. You know, every so often you say, go on. And so that is that minimum encouraging. Remaining silent, you all. We have a hard time with this as healthcare providers. Silence is active listening, it's therapeutic, it is positive. So if a patient or family member, they're needing to make a decision, but they're not ready to, we can just remain silent. We don't have to just push the issue. As long as we've given them enough information and they have told us, hey, I need to wait just a moment. I don't want to make the decision right now. It is okay. It's positive. It is active listening to just be quiet and remain silent. Summarizing, stating the main idea of the information that you've gathered. So the patient, you've asked those open-ended questions, and then you go back and give us 3 bullet points based on what you think the main idea is from what the patient has said. And then validating allows the patient to correct the information when we summarize it so that we ensure that the information the sender has sent, that we received it correctly. I think we have a slide on this when we do the individual activity because we do need to know these different examples. Okay. What is the difference between clarifying, restating, and paraphrasing? So I wanted to mark this part up, but so come off mute. Let me hear from you again. How do you just take one of the terms here, clarifying, restating, and paraphrasing? How do you know or tell the difference or remember or recall the difference between each of those or one of those? How do you keep it straight by knowing the difference between paraphrasing and repeating and clarifying? So let me hear from you. Come off mute. Two people, at least 2. We can hear from more.
I think that
Go ahead.
I get the restating and the paraphrasing. I keep them different because just restating, I just think about you just restate what they say in a different way, and paraphrasing is just like put it in your own words of what you think the patient means.
Okay, so you're
And
saying
clarifying would be just the close-ended questions.
Okay, so restating, you're specifically just parroting back what they said. Whatever they said, you're actually restating what they said. And then paraphrasing, you're putting into your own words just for, and I think paraphrasing is it also helps us to really understand what is being communicated. And then clarifying, tell me again what you say for clarifying.
For clarifying, I said like asking the close-ended questions in response to be sure that you understand. Clarifying, I just think of being, just clarify it, make sure that you understand.
Exactly. The example, like what I just said, well, hey, can you tell me again what you mean by clarifying? And so then you restate what you're saying just to make sure. I heard what you said the first time, but I asked you to restate it and tell me again. And so that you make sure. So now I can say, well, you say that you're restating it but you just want to ensure, yes, this is what I really mean, or yes, or no, this is not what I meant when I said that. So good. Thank you. Anyone else? Because you're going to see this. HESI, and they're going to have example statements. So you're going to have to be able to determine which is which. Anyone else? So come on, we're going to help you. Talk us through clarifying, restating, and paraphrasing. One other person.
Clarifying is a lot more specific. So like in the example that they put, you have to be, it's closed-ended. So clarify what you mean by that. Clarify, what does that pain feel like? Is it sharp? Does it radiate? That's a moment where you're clarifying, versus repeating is when you're taking down notes and you're just again repeating what the client is saying to confirm. And then paraphrasing, just putting it in a different arrangement of words or your own words.
Okay.
But there's some.
Thank you all. Thank you. Good, good. All right. So positive communication techniques, developing trust through openness, honesty and integrity and dependability, using I messages, establishing that eye contact, not sustained eye contact, but that, that brief eye contact, look away, keeping your promises. Remember, the patient asked you to go get some ice, and then, if you can't make it back, delegate or ask one of your team members to take it back to them so that it won't look like, you're not trustworthy. Expressing empathy, using that open communication, clarifying information, and then be aware of body language. The patient, you're talking and they're looking away or they're frowning, facial grimacing when you're asking about pain. They're saying that they're not in pain, but then the nonverbal doesn't match what the verbal is. So then being aware of it so we can ask those more focused questions for clarity. Yeah. So factors that affect communication, it includes age, gender, income, and then our life experiences, even our cultural characteristics, just that personal space, that sustained eye contact. It may, if it's frowned upon or disliked, then there may be cause a problem with us communicating with our patients. If we that personal space, usually you can just tap somebody on the shoulder, but if it's unwanted and it's against whatever their cultural beliefs are, then it may affect communication. They may shut down on it. Situational, we talked about that noise, these alarms and bells and whistles going off. The odors, we're getting ready to do a dressing change. I already know that that wound has an odor to it. What can we do beforehand so that that dressing change is more pleasant for that patient? And so the situational, and then context, background, and circumstances leading to the conversation. Situational, you all, we need to know that, all of these things affect communication. But they're in pain and they're continuously hearing these noises go off. And you'd be surprised when you go in, or your responses, them being non-compliant. If that environment, that situation is unfavorable, then they kind of shut down on you. Or you may get responses, it may directly affect their emotional state, their response to you. They may not be as cool, calm, and collected and cooperative. Depends on what's going on in that situation. Okay. My little alarm's going on, so we can be on time for your break. We still got a few more minutes. All right, so then let's look at negative communication. This one right here, we don't want to give advice. They're going to ask, hey, nurse, what would you do? And they genuinely don't mean anything by it. They really want to know what you would do in that situation or what your response would be. But we don't give advice. We make sure that patient have enough information so that they can make an informed decision. We don't judge. If we're doing home health and we're going into that client's home and they have clothes on the chair, they have dishes in the sink, we don't provide judgment. As long as we're safe and they're safe, we move on and provide that care. We're in the emergency room and we have a patient that's a frequent flyer. And whatever day of the month, we know more than likely that patient's going to come in because they've run out of medications. and or they could be an alcoholic. They could be homeless. We don't want to provide judgment. We provide that same best care, uninsured, underinsured. We don't provide judgment. We still provide that best care that we can. But this one right here, that giving advice, we kind of don't think that that is negative communication, but it is. All the rest of them we pretty much are good on, but that giving advice. But because we don't belittle false reassurances. This is one here too. Everything is going to be okay. We don't want to say that. So if they need more information, they ask you about a surgery or this new treatment, well, if they need more information, we get them more information. We bring that doctor back in, bring that dietitian back in, that whomever's putting in the sleep or whatever it is that they need more information about so that they understand the risks, to whatever it is the intervention is that they're doing or getting ready to do. Whether that is surgery, new medication, or whatever it is. We don't want to say everything is going to be okay. Okay. All right, so we got another knowledge check, and then that should take us to our break here. So in the chat, place your answer, A, B, C, or D. In the chat. Give you a little minute to place your responses in the chat. Okay. According to the text, women often end sentences with questions while men make, what are we saying? Women often tend to make statements that end with a question where men make, let's see, my little chat isn't pulling up. Let's see that we get it. We have B, everyone's saying B. So that's declarations, right? We go back to the slide. Yes, and that would be correct. All right. And so we have 6 minutes before we go on break. So let me just stop and let's go back and recap some things. Let's just make sure that we're all on the same page here. So would this be interpreted as aggressive, making brief eye contact? You can come off mute and say yes or no.
I don't think it's aggressive.
What about if I'm leaning forward, making and glaring eyes and making that sustained contact? Is that aggressive?
Yes, it's aggressive.
Could be considered aggressive. Okay. So we're going into the client's room. We knock on the door. What are those steps that we do to go in that client's room? After we get in there. Knock, knock. They come in.
Announce who you are and tell them what you're there for.
Okay. So we provide the client our name and we identify ourselves. I am Susie with Fortis's LPN program or Fortis's ADN program. I am Susie, the physical therapist. So we knock on the door, wait for entrance. Of course, we're going to do our hand hygiene. No, that part is there too. We provide the client our name and then we identify, who we are. Then what do we do next?
We identify the patient, make sure it's the correct patient, and then we explain what we're going to do, like what we're there for.
We ask the patient the preferred name they would like to be called.
Okay. So, clarification. After we knock on the door, we do our hand hygiene. We tell them who we are and we identify ourselves. Hi, I'm Susie, physical therapist. Hi, I'm Susie, the student nurse. And then we verify who the client is. We ask the client their name and date of birth. And then we ask them what they prefer to be called. Because a lot of times, even though they're Mr. Frank or Mrs. Jones, they want to be called Sue, Bob, or whatever their nickname is. Knock on the door, hand hygiene, identify who we are. And we say our name and identify who we are. We're Susie, physical therapist, Susie, the nurse. Identify our client. Have them state their name and their date of birth. And we'll look at their name tag too, but we want them to state their name and date of birth, and then ask what they prefer to be called. Okay, a few more minutes. We just said that women often end statements with questions. Is that true or false?
True.
Okay. So with the standardized care plans, all options will be available. Is that true or false?
No, because it's not personalized to the client.
So with the standardized care plan, are all options available? Remember, they all are available, but we want to make it into an individualized care plan, which is Perez took us to. She said that we want to make it individualized. But remember, the facilities buy these packages. All those options are there, but we want to flip them into an individualized care plan by taking away the options that do not apply to your client. Okay? So, S-bar. We are calling because we're making a phone call to the physician because the patient's had a change in mental status. Which part of the S-bar is that?
Situation.
What about we're calling the doctor because there has been a medication error? What part of S-bar is that?
Would it be assessment?
Background?
What was that? What was that?
Recommendation.
We are calling them because there has been a medication error. We're making the phone call.
So is that background? Or would be situation?
What is the definition of situation?
Something that's
Assessment.
Situation is the reason that we're
Then
calling,
we are
right?
calling.
yeah.
Oh,
Okay. So we're making that phone call because there has been a medication error. We need to report that, a medication error. Medication error, lab results, change in mental status. All those are different examples of situation. And I think sometimes we get mixed up on the assessment part too. So let me see. Oh, I gave you the answer. I was going to give you some examples, and the answer was going to be assessment. So I'll ask you that at the end. So let's go over some more. Let's see what else comes to mind. Let's see, just see. The patient, which part of the S bar? The patient has a history of hypertension.
background.
Okay. The patient takes metoprolol.
Background.
Background?
Background. Okay, good. Let's see what else. Is this open or closed? And that's our little clue for our break. Let me just I'll do it when we come back. Because I want to stay on time because I run over time, y'all. See you in 5. Okay, we have everyone back. So review from last week, the different healthcare workers. Everyone is an important part of the healthcare team. And so when will we call upon a dietitian to assist us? What could be, someone give me 2 scenarios where we would call in for the dietitian or someone from the dietary department to assist us with our client.
Patient has a special diet, like they're on a kosher diet.
Okay, great.
Diabetic diet.
Okay, so whether or not it's cultural related and or disease process related. We can bring them in. That client may need extra calories because they have a certain disease process, or that client may need a different option because for the most part, they have these meals already planned because they have to go through and look at the calories you all, they have to look at the different food groups. And so that's why they traditionally serve what they serve, but they also have alternates. So we have someone that's needing extra calories because whatever disease process, and or their cultural preference is something different that's what's being served. So we arrange for that visit from the dietitian or someone from that dietary department. What about the social worker? What do they do as being a part of the healthcare team?
They need help with placement upon discharge.
Helping with resources.
Yes, great. Assisting, identifying those community resources, those agencies that are out there. Someone else was going to say something? Smith? Okay. So
Oh, no, I
yes,
answered helping with resources.
yes, assisting those with identifying those extra resources, usually upon discharge. They're getting ready to go home. They might need an oxygen concentrator. They may need Meals on Wheels. So identifying those community agencies and or resources that are available.
They can also help with when patients come in and like they don't have insurance, so getting their insurance set up to help cover their bills.
Exactly. Yes. Even on the opposite of that, and they have insurance, and then because what is it, what I'm trying to say, the income, the amount of monies that they have may be more than what's required for that insurance. So they know about that process of spending those funds down, is what they say, on things that are allowable so that they can qualify for that insurance or those different type of insurances. Okay. And then what about the nurses? What do we do? Everything from A to Z. Yes, and in between. But yes, so we do the teaching of we administer the medications, we reinforce the teaching, and so forth and so forth. And so we do everything from A to Z. What about physical therapists? What do they do?
They help with rehab.
With rehab. Okay. And so patients post-op having surgery, that's most of the time, or even if they're post-stroke, and getting that client back to as optimal level as you can, post-surgery, they'll work with those clients. So they'll have them in their in therapy rooms, climbing those stairs. They'll have them in those hallways, walking, putting things. I think occupational is where they have them folding clothes and things like that. But everyone is part of, just as important team member of that healthcare team, because we all play that important part. And then never mind, the nurses do everything from A to Z in between. All right. Are there any questions about the members of the healthcare team? Okay. And we kind of touched on this on one of the slides that we had, but I want to go back to it. The client, I think we gave you 3 clients. One client was lightheaded, one client was post-op, the other client was respiratory difficulties. We always want to consider safety, no matter which client we have. If the client is dehydrated, if the client's a diabetic, if the client's post-op surgery, we want to consider safety. Make sure that we're implementing those fall precautions, thinking about whatever it is so this person does not fall. So for all of those clients, those different examples that we gave. So we're trying to, what's that most important action when we're trying to determine or come up with a plan of care? We're collaborating with the RN, and we're collaborating, and we're just trying to come up with the plan for our patient. What's the most important action that we need to assess about that patient? When we talked about it's important to include our clients in their care. So what do we need to find out while we're trying to come up with the plan of care? We need to find out about that patient.
Their goals.
Their goals. What else?
Their needs, their preferences.
Their preferences. What else? Patient has diabetes. Patient has hypertension. Patient just had a hip fracture. What else we need to know?
How much they understand about their condition.
Exactly. All from that list, all of those were great ideas. The priority of the most important was assessing what they know about that condition that they have. So all of those are things that we will talk about, but at the top of the list, we need to know what is their understanding? What is their knowledge base? What do they know? All right, so let me hear from you. What are those 4 terms that that the Department of Education describes that what we do? They've summed it all up in a nutshell with 4 words. What are those 4 words?
Judge.
Judge, recognize, determine, and appraise.
All right, let me share my screen here. Let's go back to our PowerPoint. That was good. That's what it was. Okay, so now we're getting ready to talk about the different behavior styles. Let me see here. Yeah. Okay. Non-assertive, passive, aggressive, and assertive. So let me hear from you in the chat. Let's put it in the chat. Let's talk about aggressive. I think pretty much everyone knows that one right off. So in the chat, just give you a minute. Just give us a one-liner. You know, what's the definition if you're explaining to the class? And send your response out to everyone. We're going to talk about aggressive first. Just put a paraphrase. Give us your definition of aggressive. Let me stop sharing so I can see what your responses are. Aggressive. Okay, the glaring eyes, being combative, aggressive. Throwing things around, yelling, being very demanding, loud, showing anger and willingness to attack someone. Okay, speaking loud. Because remember, even if they're hard of hearing, we don't speak louder. So being loud, it is aggressive. Confrontational, controlling behavior. Okay, great. All right, so now let's go. What was next on our slide? Let's talk about non-assertive, which is also called passive. So in the chat, paraphrase, give us your definition of passive behavior. Passive. Non-assertive. So this is the opposite of being assertive. Let's see what we got. So passive. So we're talking about non-assertive or passive behavior. What is that? Okay. Looking away, not making any eye contact, fear-based behavior, avoiding answering. Okay, keep going. Passive behavior. Passing the buck. Hesitance. Not being honest, because remember, it's the opposite of assertive. Okay. Speaking softly. Okay. So what she means by speaking softly is not at a tone where people can even hear you at. Okay. Self-defeating type behavior. Okay, good. All right, continue to share. All right. So now we're going to look at assertive. So tell us what is assertive. Assertive is the opposite of non-assertive or passive. Okay, direct, firm tone, respectful, honest, good. Share your responses with everyone. We're talking about being assertive, which is the opposite of non-assertive or passive. Being stern, why tell someone to do something so you're not being shouting at them, but hey, this is what we need to do. That example that always comes to mind is that client that's talking about everything but but answering what you're asking. So you have to refocus them. Refocus and just remind them about why you're there. We are here to gather more information so that we can pass this information on to your healthcare provider. This information, that these questions that I'm asking are really important. It will help your doctor to make a decision about what's your next steps. So we're being honest, we're being firm. We're not speaking so that they can't understand. We're not shouting at them. Good. Okay. So which is this being honest, making eye contact? Great. So the example that I'm going to give, tell me which is it? Let's see. Let me think of something real quick here. Nurse Bob, and I call on Nurse Bob. You will see the little activity that we'll do here in a moment. Nurse Bob waits until after the meeting to tell or to state his opinion about whatever it is that was being discussed in the meeting. Which behavior style is Nurse Bob displaying? And you can come off mute and tell me. Nurse Bob waits until after the meeting to discuss or voice his opinion about whatever it was that was being discussed in the meeting. Is he being assertive, aggressive, or non-assertive or passive? Are you out putting the responses in the chat? Let me see what you're saying. What is Nurse Bob? Is he being, my little mouse? Oh, here it is. Let's see. Okay. He is being passive or non-assertive. Exactly. So that means we are avoiding. That's avoidance. That could be being dishonest, just passing it along. Good. That's good. All right. Let me think of another one. The other example I gave you, leaning forward, glaring eyes. We got that one. I gave you an example of assertive. Okay. All right. Let's move forward. All right. So here is another one. It says behavior styles. Which style would be used to advocate for the patient? Which one of these would be used to advocate for the patient? And you can come off mute and just say it out loud. Assertive, non-assertive, or aggressive. We're advocating for the patient.
Assertive.
Okay. What about which style would pass the buck? Avoidance, overlooking, not addressing. Which style?
Passive.
Okay. So it is passive or non-assertive. Okay, good. And then notice I said the same thing as passing the buck, but I just said it in different ways. So test taking tip, as you're reading, think about what other word or phrase is used to as an example of that. Okay, then the last one, which style would be confrontational?
Aggressive.
Aggressive.
Got it. Good. Okay, great. Does anything contribute to the risk for workplace violence? And the example that and I think we talked about this last week as well. In the one of the facilities, they always ask us to park in this parking area because they want their customers to park up front. And so the parking area is far off, the lighting is poor, and it's a good distance. So we have to think about, as we go into work, our clinical settings, are we safe? They're asking us to walk this, even the students, we couldn't park up front. When we go in for clinicals, we have to park that same distance. And then what is the condition of our client for that location? Of course, I told you all they end up having a van service. So they coordinated with the highlighted times that people were mostly changing shifts. And then in addition to that, they added to that facility, the staff had the security's phone number, the person that actually drove the van. Even though they identified the most times that people were changing shifts and would utilize the service, there are some times that you run behind shift because something happened. And so you're not reporting to that place at that specific time, but you need a ride at another time. So they added another layer where you can call and say, hey, can you pick me up and drop me off at the area? So think about the location, in the long-term care facilities and even in the hospitals, the doors, what time do they lock? What time are they locking these doors, or are the doors always unlocked? Whose responsibility is it to lock those doors? They should be locked at certain times. And the entrances, as as the day go along, there are less and less people there. So the entrances are usually locked as well. There's not as many entrances and exits as it is in the daytime. And then we want to consider our client's condition. Our client could be going through detox. They could be having a mental issue going on where they're combative. And so we do want to consider that because, we can end up being injured. If our patient has had some type of head injury, they may be hallucinating, seeing or either hearing things that are not there. And so we want to consider that because we want to consider our safety as well as theirs. Okay. Sexual harassment. What should we do if we're the victim of sexual harassment? If you are the target, remember the first step. We need to remember this first step is to confront that person who is harassing you. You need to know that first step. Tell them in an assertive response. You're being honest. We just talked about being honest and assertive. Clearly what they're doing is offensive and it is unwanted. Be firm and assertive. And then your message must be congruent so that what you're verbalizing and our nonverbal and verbal equals the same, so that there are no chances in miscommunication. But first, we want to confront the person who is harassing us, telling them, hey, this is unwanted. We do want to provide that cultural care and include that's all part of taking care of our patients. So we need to think about our cultural skills, cultural competence. We need to gain knowledge and skills that allow us to be able to provide that best care. Just like we were talking about the dietitian earlier, we bring that person in. If someone culture requires them to eat a certain meal or certain food items, we want to bring that in, have that dietitian to come in because we want to provide that culturally competent care for our clients. We want to be aware that not everyone eats the same thing. And it's okay, just being aware of the different cultures. The cultural diversity, the many differences and elements of culture in groups of people in the American society. This is a nice little mix. And then enculturation, process of learning your culture, the way we group things and things are done. Because we do want to provide that culturally competent care. We just said out of all those things we listed, assessing the client's knowledge and understanding, but we want to also include what their preferences in. We want to include that, but still that number one thing is assessing their knowledge. But we do want to also include their preferences. If they want a person of faith there, If they want the windows open at a certain time, no, not the windows, but the blinds open. As long as we're not being harmed or they're not being harmed, we want to incorporate those different interventions into their care. And so remember the eye contact. You know, sustained eye contact is usually offensive. And so also be careful with the touch. You know, sometimes that space is not welcome. You know, even though it is a safe touch on the pat on the shoulder, if it's not culturally responsive, then we don't want to do that. And we talked about the bringing the dietitian in, learning what do they eat, when do they eat it. It may be that they want their meal an hour later, and so we incorporate that in them provide getting their care because we do supposed to feed the patient, offer them the food, right? And so in the event that they have to eat at a different time, we want to incorporate that. And it seems simple, but you know, it's very, very important in us taking care of them. We need to know the negative effects on culture. What are they? Discrimination. What is that? What is prejudice? What is ethnocentrism and stereotyping? So, ethnocentrism, believing that one's culture or view is the only way, that is superior, this is the only way. Okay. So, stereotyping, assuming that everyone from a specific group, everything is the same for that particular group of people. Okay, and discrimination, withholding rights and privileges of another from someone. Just like we said that we know that patient, the example I gave, we know at a certain time of the month, this patient may come in because they're out of meds or they're out of supplies. We still going to provide the best care we can for that patient. We're not going to withhold care because we know that they don't have insurance or underinsured. Okay. But ethnocentrism, belief that a cultural group view or way of doing things is superior, that this is the only way. That's ethnocentrism. I think that's the term that is pretty much new for everyone. But that's what it is. This is the only way. And everyone else's way is just null and void. No, that's incorrect. So in the professional healthcare team, we kind of talked about this. And so everyone is just as important. We need everyone to provide this best care we can for our patients. We're going to work together to meet that common goal, which is to provide that best care for our patients, to get them back to that optimal, back as close as we can to their norm as we can. We said the physical therapists, they will come in and they'll do those exercises with the patients and have them walking up the stairs, walking down the stairs, walking in the hallways. The social worker identifying the resources that are in the community, whether or not it's Meals on Wheels, helping them get their insurance if they underinsured or no insurance, getting that insurance, filling out that application, getting that oxygen concentrator to that house. That dietitian coming in and seeing what those meal preferences are. What is it about the meal items? Or is it the time that the meals are served? Bringing everyone in. And then we said the nurses, the little nurses, we do everything from A to Z. We're that point of contact. All right, so some things to consider. Is it important for the nurse to accept the client's right to their belief and neither agree nor disagree with their choice and respect their right to refuse treatment or medication? So we do want to make sure that they have enough information so that they can make an informed decision. And they do have the right to refuse, but we want to make sure that they have all their questions answered. Sometimes you will see patients, they know that they're hurting. They're telling you that they're in pain, but sometimes they'll just hold off on the pain medication. They'll say, no, want to hold off. And sometimes it could be because of a cultural belief, or they just don't want to take that medication right then. They want to try some non-pharmacologic. They want to change the position, dim the lights, get a heating pack or a cold pack, or give them some more pillows. So we do want to, so we make note of that. We don't want to try to change their minds. Okay. If a client asks you to pray with them or perform a baptism, what would you do? We can baptize the clients. We can baptize the clients. Some clients may belong to a religion that does not believe in certain medical treatments. Never assume what a client's choice will be. We want to make sure that they're making that decision. We offer them the choices and let them make the decision. So clients may have different food preferences or times to eat. We talked about this. We want to utilize the appropriate healthcare team member. Don't try to do even though we do everything from A to Z. Don't try to do everything every time. Bring the other team members in, get their assistance. Okay. What are those 4 terms that are used to describe our scope of practice?
Judge, determine, recognize, and appraise.
Okay, judge, recognize, appraise, and determine. So let's go back from day 1, week 1. What are those things that have changed since the 21st century for nursing? Give me at least 3 things. Tell me about 3 things.
Pay.
Okay.
Job opportunities. The
Okay.
license.
Okay. What else?
Technology.
Okay. Great. What else? What about the nursing programs? They've changed. Remember those nursing programs? Now
They're more flexible.
Exactly. Initially, it was one size fit all. Monday through Friday, brick and mortar. Now we have accelerated. We have half-time, part-time, hybrid. There's a variety. The salary gap, it narrowed. And then the National League of Nursing, they recognize that we are just as important part of the healthcare team as the next person, the next nurse, the next therapist. So the 3 things out of what you all said, we can narrow it down to, we are recognized, LPNs are recognized. The National League of Nursing made sure that, hey, they are just as important. And because of that salary gap, it narrowed. So there was this huge gap. But now, because we're a valued member of the team, the salary gap between the nurses have narrowed. And then to help with the shortage, the nursing programs, there's a variety now. And so that we can choose accelerated programs, or part-time if we need to. So is the following information subjective or objective? A wound odor.
Objective.
Body odor.
Objective.
What'd you say body odor was?
Objective.
Okay. What about we checked the temporal temperature and it is 100.1 degrees Fahrenheit.
Objective.
Oriented times 2. They're oriented to person and place, or they're oriented times 3 to person, place, and time.
Objective.
Okay. The patient is rating their pain as a 0 on a scale
of subjective.
Okay. All right. So what do? We go in and we measure the vital signs. We get a respiratory rate of 24. What do we do before we go and report that information?
We recheck.
Recheck it. Take a while and recheck it.
We verify it by rechecking it. Exactly. Not to say that our count is wrong. Even if it was a blood pressure measurement, it is abnormal. We want to verify it, because what are we going to do? More than likely, we're going to get some type of intervention. Once we report our findings, they're going to tell us to do something. We're going to get some new orders. But we want to make sure that the information that we have is valid. So we verify that information. So what are those 2 parts of the nursing process where the LPN functions more independently?
Evaluation and implementation.
Assessment and implementation.
Assessment. It's assessment where we're collecting that data. Remember, we're doing that head-to-toe assessment. and then when we implement those interventions that we're doing.
So when do the LPN do the implementation and evaluation part?
So so we have implementation. So first off, two pieces. We function more independently when we're collecting the data, when we're assessing, when we're implementing, when we are reinforcing that teaching, we're administering that medication. We get with the RN to evaluate. We're reporting our findings from the implementation, the things that we have done. That's what that evaluation piece comes in at. We're talking with the registered nurse, and we are discussing our findings from the implementation. So again, just for clarity, what are those two parts where we as the LPN function more independently?
Assessment and implementation.
An assessment is collecting that data. And the implementation, that's the action part. With whether or not it is reinforcing information that's been taught, or if it's administering that medication, or if it's doing a dressing change. Okay. Clear on that part? Okay. All right. So I want to do this short activity, then we'll review information here for our quiz here. So I'm going to send this to your mailbox. We give you all about 10 minutes to look over it, just to make sure we don't have any questions about it. Let me save it here again and send it to your mailbox. Let's see here. Okay, and then I'm going to send it to your Canvas mail. We're just going to spend a little time looking back over it, and then we'll move on. So hello, time be going so fast, y'all. I know y'all be like, no, it is going fast enough, but to me, I'll be running out of time. Let's see here. Let's see here. And let me find you all. And I'm going to attach it. And it's just gonna just say activity. I'm just gonna say see attached. So we're just gonna spend a few minutes looking at it, and it's recalling and verifying what you already know, but then it's gonna help you identify those concepts that you need to start working with first as you continue to prep for your exam and as well as your HISI. So it is still spinning. Okay, so the message was sent. So go to your Canvas mail, and we'll just spend just a few minutes on this. Let's just say about 7 minutes. I just want you to look through it. And I'm going to put you in breakout rooms, just random breakout rooms. Let's see. So go to your Canvas mail. And let's see here. Yep. And just accept the invitation to the breakout room. Put the timer on for 6 minutes. Look through the activity and see what concepts you still need assistance with. And then we'll come back to whole group. All right, everyone should be back in about 45 seconds. And so, yes, that is the information that we just went over. But you just look at it in a different way without the information being there. So that helps you to identify, what concepts you need to start working with first and so forth. So that's what that activity was for. So let's just do. Let's see here. Let's review some more concepts here. All right. So if a person says that they are spiritual, what are they referring to? Or what does that really mean? True or false? If a person says that they're spiritual, are they are referring to the fact that they may have deep beliefs and values and they're guided by a higher power. Is that true or false about someone who
True.
says that they're spiritual? So
True.
they have deep beliefs and they feel that they're guided by there's some interaction with a higher power. I do agree with that. That is true. Okay. And so when we're talking about cultural concept of culture, remember culture is that behavior that is learned by members of a group and is passed down from generation to generation. And it does acknowledge the view of the world from others that also have a similar standpoint. There is we should consider that because we do want to provide that culturally competent care. I was hearing something, that's what I was looking to see. But cultural is a behavior that's learned. It's about, what, and it shapes what we do and what we don't do. And then as it's passed down from generation to generation, sometimes things are just altered a little bit. And so, but nevertheless, that is culture. And in providing that culturally competent care, sometimes our patients may ask for a person of faith to be at their bedside to provide some type of ritual. As long as that ritual is not causing us any harm or that patient any harm, we allow them to perform those rituals. Now, persons of faith have different names. They may be called a shaman, a priest, a minister. And so that is including providing that culturally competent care by allowing that person of faith to perform those rituals. Like I said, again, as long as we're safe and the patient is safe, it's not causing anybody any harm. We're not going to allow anything that's going to, allow the facility to be set on fire and things like that. I know students people were going around, and this doesn't have anything to do with culture, but I think it was a TikTok thing where they were starting fires and stuff like that's causing harm to someone. We're not going to allow something that's going to cause harm to the patient or ourselves. But if they want that person of faith, and those person of faith have different names, titles, shaman, priest, minister, then we include that. We allow them to perform those rituals. And that is part of their culture. And it's something that they've learned that's been passed down from generation to generation. And it's part of them being spiritual because they may believe that ritual that's being performed connects them to that higher power that, plays a part in their life. So which concept best represents this statement that I'm going to read to you? Each client they are unique and they have values and they may differ. Is that an example of stereotyping or philosophy of an individual's worth? Each client is unique and they have values that are unique and should be observed. Is that an example of stereotyping or is that an example of philosophy of an individual's worth?
Philosophy of an earth.
Okay. That is the philosophy of that individual's worth. What is this an example of? My way is the only way. No matter what no one else thinks or says, it doesn't matter. What I think is the better way. Is that an example of prejudice or ethnocentrism?
Ethnocentrism.
Okay. Remember, ethnocentrism states that there is only one way, and that's my way. It's superior. Whatever else is going on or whatever everyone thinks, is null and void. There's only one way. That's what ethnocentrism says. Critical thinking. Critical thinking is not outcome based? Is that true or false? True or false? Critical thinking is not outcome based. Is that true or false? Is it false? What would make that statement true? Critical thinking, fill in the rest.
Is it evidence-based?
Is outcome based. So critical thinking is outcome based. So that's true. So the question that I asked you, so again, test taking tip, make sure that you understand what the question is asking you. So I said, critical thinking is not outcome based. Was that true or false? And it is correct. That statement is false. So then I asked you, well, what makes that statement true? Well, taking the not out of it. Critical thinking is outcome based. That is a true statement. Did I confuse you all with that, or do I need to restate that? Critical thinking is outcome based. So the test taking tip takeaway from that is, as you're reading through the question and the answer choices, you can look at the answer choices and say, well, this is true or false. And that will help you eliminate some answer choices. Because go back to your foundation. What do you know about this concept? Well, critical thinking, it is outcome based because we're trying to have a positive outcome for this patient. So as we communicate to our physician, we're calling to tell them what the situation is, whether or not that's a medication error, a change in mental status, a lab result. And so we're making that call because we want an outcome. We want a positive outcome for that patient. We need an order. We need our next steps. So critical thinking is outcome based. Any questions about critical thinking before I move on? So I'm going to bounce back to the cultural care. How can we develop cultural competence? How can we provide that better cultural care for our clients? We want to recognize how our culture affects our own thinking. The nurse do. We need to realize that. Then we need to learn to be flexible. If they want that person of faith there to perform that ritual, is not causing us any harm or them any harm, then it's okay. And then we want to discover how our clients are unique, despite their cultural group. Because like we said, culture is those ways and views that are passed down from generation to generation. But sometimes those things are changed. They're changed just a little bit. So first of all, we need to recognize our own thinking, our thoughts about culture. And then we need to learn to be flexible and include our client values and their preferences in their interventions. And then discover and remember, we provide that individualized care. So guess what? Our clients are unique despite their cultural group. Any questions about those three statements? Okay, so we'll move on to the next concept then. So just to reiterate, culturally competent care. If we do want to preserve those practices that are helpful for our client, we want to preserve those. Now, if some practices are harmful, we want to repattern those. Hopefully that client will replace or repattern those harmful practices with something that is not harmful. And then, of course, we want to know what those health beliefs of that client is. So we want to know that, what do they believe about, what are their beliefs? Because remember we're going to talk about the theorists in a couple of weeks. But if they don't have that belief in whatever that intervention is that we're trying to introduce and do for them, then it's just something that we're trying to do. But we want to know what is their health belief. And then we want to preserve those practices and their preferences that are helpful to that client. But then we want to repattern, refocus or changed out those practices that are harmful with something that is not harmful. Okay. Any questions about what we just covered? And so I did go over that at the end of the class on last week. So hopefully you went back and went through that recording. So I was just reviewing what I went over at the end. So we are going to, I have not published the quiz yet. So just log into your Canvas. Do not click on the quiz. And so remember, if you have questions or concerns during the quiz, place a message in the chat. Please do not come off of mute. You are given the 15 minutes to take the quiz. In the event that you finish before the 15 minutes up, you can turn your camera off. Just log back in or make sure your camera is back on at the return time. Right, we need everybody. I have not published it yet, so don't click on it. And then I think I have my time right this time because it is Pacific time and we're all different time zones, but the Canvas is Pacific. So, all right, we got everybody back. And so let me click publish here and I give you the password. Just looking at my time to make sure I have it right. So, okay. Just gonna move it up 1 hour earlier just in case. Let's put it here. Okay. All right. And I will place the code in the chat and I will go on mute. Make sure you're muted. You can find the quiz after I publish it. Get ready to publish here. Save and publish. The quiz can be found in the grade book or under the module section. So, and placing the code in the chat. Okay, going on mute. Everyone is finished. Come on back on. All right. So, true or false? Culture is a behavior that is learned by members of the group, being passed down from generation to generation. It does acknowledge the view of the world from others and from similar standpoints. Is that true or false about culture? You can come off mute and tell me. Is that a true statement about culture? Hello, are you there? Is that a true statement? Tompkins, what you saying, yes or no? Angelo, is that a true statement?
True.
Okay.
True.
All right. So this is your safe space. If you get it incorrect, I'm going to correct you. So that is a true statement. All right. So because we are providing culturally competent care, should the nurse withhold pain medication and not even offer it at all?
No.
So that is correct. That is, I agree with what she's saying. We should not offer it. We're supposed to offer it, but let's take it a step further. What if that client's religious belief allows them not to take pain medication? So does that mean that patient did something wrong or bad, or is it just probably part of and they're telling you it's part of my cultural belief that, because of what I've done, do we automatically assume that they did bad things?
No.
Okay. So it's just part of their belief. It could be that that they didn't take the trash out on Monday, Wednesday, and Friday like they were supposed to. They took it out, but they took it out late. So the garbage truck didn't pick it up. So we don't want to assume and jump to that they did bad things. So, but something wasn't followed or done like it was supposed to have been done. So as a result of that, in their beliefs, they want to refuse the pain medication. Does not mean that we do not offer it. But what if they want a person of faith at their bedside, like a shaman, a minister, and that that person wants to perform rituals. Do we allow that?
Yes.
As long as it's not causing us any harm or them any harm. All right. True or false? Ethnocentrism is a positive way of thinking about cultures.
False.
Oh,
Exactly, because remember, in order to answer that question, we got to go back to what is ethnocentrism. And it is the belief that their only way, my only way, your way of thinking is the only way. Never mind what everyone else thinks. This is the only way. So ethnocentrism is not a positive way. So make sure that you're reading the answer choices, the test taking tip. You can read each answer choice and say, well, hey, is this a true or false statement? Well, how do you know? You have to know what that concept is. And then if it's not a true statement, you more than likely shouldn't pick that answer. Okay, true or false? All clients from a cultural group share the same beliefs and practices.
False.
That's
False.
false. Because remember, culture is those beliefs and practices that are passed down. But remember, each generation and generation may change a little bit. And just because I belong to this cultural group doesn't mean that we all have the same. Test taking tip, look for those words that will eliminate that answer choice altogether. Words such as but, all, the same, those words, that one little word will make you not select that answer choice. Okay, so we do want to discover how each client is unique. We do want to learn to be flexible, and then we want to recognize our own way of thinking about culture. So we do want clients to, we do want to preserve practices that are helpful to clients. We want to incorporate that in their plan of care. Do we want to assume that clients are going to follow the plan of care just because we come in and say, hey, this is what we want you to do? Exactly. That one word makes it wrong. Assume that we don't do assume anyway. But then remember, the client has a right to autonomy, and we support that. Just because we have this outline as their plan of care, they have the right to refuse. Going to that client that's practiced Hinduism, their cultural beliefs in pain medication, that person refused the pain medication in the event that they were really in pain. But because of that belief, and our plan of care says offer this pain medication and administer it every 4 hours, that patient can still refuse it. So we don't assume, and clients have the right to refuse plan of care, even though it might be the better thing for them. And then remember, we want to repattern harmful practices. We want to replace those practices with something that is good and that is helpful to that client. And we did say that each client is unique, and they're regardless of their differences, they're unique, and we're going to provide that best care. We're going to preserve their cultural preferences if we can, as long as it's not harming us or them. And that is a philosophy of the individual worth of that person. Spiritual, true or false? It means that the person is very religious and has to pray every day.
False.
True or false? Spiritual means that that person will display exaggerated emotional outbursts.
False.
False.
True or false? Spiritual indicates that a person has deep beliefs and values that guide their life, that helps them make decisions, and that there's some connection with a higher power.
True.
Okay. My way is the only way of treating this illness, or my way is the only way. What is that an example of? Prejudice or ethnocentrism?
Ethnocentrism.
Okay. Critical thinking, it is outcome based. True or false?
True.
Critical thinking is being judgmental. Is that true or false?
False.
Critical thinking is based on subjective thinking only.
False.
Okay. And so that's how that we just demonstrated that test taking tip. reading each answer choice. First of all, what is critical thinking? Then see if the answer choice is correct or matches that concept. All right. And so let's go over some few housekeeping things. If you are repeating any course, if you're a re-entry for any reason for any of your courses, as a reminder, remember to check in with your professors weekly. Email, text message. Email will be best, and or via Zoom. You do want to complete the practice exam for all of your courses. You might see, I think there are probably 2 for my course. I think Dean Brown put one in or ExamSoft put one in, but complete all of those practice exams. It's just going through, making sure that you're ready for your exams, which will be next week. Go in and complete all practice exams. Look in the announcement section for the passwords. They're either Fortis 01 or either Fortis 02. You need your IDs for your exams. Please have those on you. If you're going to use a dry erase board, make sure you have that in hand. Exam review sessions they will start on tomorrow. I think Dr. Tenz's is tomorrow. Attend if you can. If you cannot, at a minimum, commit to going back, looking at your classroom recordings and the exam review links that will be provided. All right. Well, that's the end. We're going